to the bones. They're going to need to take out the screws. Okay, they need to have a very dense motor block.
What do you say about musculocutaneous block? Is this sufficient to block it?
This, yes, that is the advantage of actually blocking at this level. You don't have to actually block musculocutaneous separately.
Yeah, as you can see, in axillary, this is far much superior to the axillary approach. So where the musculocutaneous is already separate, but here the advantage of infraclavicular is, as sir said, you get a block of musculocutaneous also.
क्या लग रहा है आपको? कैसे हाथ कैसे लग रहा है? नॉर्मल हाथ नहीं, ये इसको निकालो. ठीक है, आप उठाने की कोशिश करो.
बारे थियो हाथ.
थोड़ा हाँ, बस थोड़ा नहीं पूरा
हो जाएगा धीरे-धीरे.
This is actually slower. So this is slower response than the VIB. VIB actually it is very close. Everything is close by.
Okay.
Whereas here the nerves are lying around the artery here. Whereas in VIB they're lying on one side. So that's why VIB is actually a good. People are just afraid unnecessarily.
Any comment? Huh?
Hello.
Yes, we can hear you.
We cannot hear you properly, sir.
I was telling that the in VIB all the cords are lying on one side of the artery, to the lateral of the artery. And that's why when you actually inject a single thing, then you actually get a very dense block. With the subcoracoid approach, you can still miss out because we try to actually move the needle around. They're just like axillary block. The nerves are lying around the artery at various positions. And so we can actually get, and if it doesn't spread properly, then you can get sparing with it.
Palpate the clavicle first. Palpate the clavicle.
Anything you
it will
want to
be
ask
lying just below the clavicle, not here, somewhere here.
Hetal?
Hello? Hetal?
Yes.
Yeah, any other questions?
There was one query. Where should be the negative electrode placed in such blocks?
Yeah, negative is always CNN. Yesterday you missed out the CNN.
No, he means to ask how much away from the puncture
It doesn't
point.
matter. You can put it on your head, forehead, on your ear, on your nose, on your body, anywhere. It is patient acts as the conductor.
It is according to your convenience. It is according to your convenience.
Not on the hand also?
No, you don't have to put it on the hand.
Oh.
You can put it on his buttocks as well if you want. Whichever is your favorite anatomical part, you can attach it there.
I will ask one question to Dr. Shiv.
Yeah.
Any comment regarding the concept of axillary sheath?
Yes. Cervicoaxillary fascia. Cervicoaxillary fascia actually covers all your, the trunks, the divisions, the
axis. You imagine in the intraclavicular, it is much away. If you have access to the C-arm, which is there in the ortho-OT, you can check when your needle is.
The next block.
It's a fascia iliaca block. Dr. Shiv sir will be demonstrating it. This is a patient of operated patient of GHR. We are for demonstration purposes we are giving the fascia iliaca block. It's a LOR block, and it will be used for pain relief. So
can I have a mic, please? Yeah. Hello, Hetal, can you hear me?
Yes, sir.
Okay, we're going to use the technique we say we can give a block with just needles. Okay, so I've got an 18G needle and I've got 21G needle as well here. So I'm going to actually create the parrot beaking. So you can see both the bevels are facing each other. You go in, okay, and you start bending in that. Okay, it's already bent. Okay. I don't know whether you can see that or not. Can you appreciate that?
Is it in focus?
Yes, sir.
Can you see the parrot beaking?
Whitening.
Okay, yeah. So we're going to use this to demonstrate that. So just a needle and some local anesthetic, you can give good blocks. Okay. Okay. So now the marking of the thing, Sadish will show that.
Markings is the. What is the line you take? Is it inguinal ligament or inguinal crease?
Yeah, no, we're going to go to inguinal ligament.
Inguinal ligament.
Yeah, we're going to
so
go
the puncture point will come somewhere in the crease in most patients.
Yeah. So we got the antisphenic spine.
One must remember these are two different lines. Inguinal ligament is different, crease is different. For some blocks you have to take crease. For this particular block, sir said that he takes inguinal ligament. So I will mark the inguinal ligament.
Yeah. So he got
this is the anterosubeiliac spine. somewhere here, pubic tubercle somewhere here.
That's
So?
the tubercle. And then
Pen is not working, but anyway,
Yeah.
this is the line. So I will divide the line into 1/3. Somewhere here. So this is the junction of the lateral
And
1/3
go a
and medial
centimeter below
2/3. And
Centimeter.
how many centimeters? below?
yeah, just one finger breadth.
Just one finger.
Yeah,
There
yeah,
is somewhere
that's
here.
fine, yeah.
There is some lesion over here, so
That's fine,
I think
that's
this
okay,
should
yeah.
be okay.
Okay. So now what I'm going to do is if you look at the thing, that bevel should be facing down. Okay. This is not much light here actually. Yeah, I can see the bevel now. Can you see the bevel? Okay. So at this point, okay, I will introduce. He's not going to feel anything because he's already had a spinal block. He's had a spinal anesthesia. Okay. So I'm introducing it at this, so it actually goes easily through the skin. And then change the angle. Okay, now it's lying on the fascia itself. Can you see that?
Can you appreciate the cushion effect? Is this the one cushion?
Yeah, yeah. Cushion effect is actually when you don't use that. Cushion effect is if you take the needle and you go straight like that. Okay, that is cushion. Can you see it's not punctured?
But the cushion effect on the first layer?
No, the cushion effect, there is no cushion effect in the first layer. Okay, so you introduce it almost parallel to the skin. Okay, you go through that. It goes very easily. Then you are straight onto the fascia. Can you feel the bounce?
That is the
And
first
you
layer where
feel,
we will get the first LOR.
Pop, okay. It's not felt that, I see. Bounce, pop.
Yes,
Okay.
that is the first LOR.
Yeah. Okay. And
Now
go
that
then.
is the second one.
Yeah. You again feel the bounce on that, and it's not feeling that well actually. I don't know whether the tissues are actually here.
Needle has not become blunt enough.
It's probably fine. Okay. Bounce. Yeah, it's not giving that kind of feel. Right, yeah.
Yeah,
Do you have not
more blunt.
Yeah, yeah. Yeah, this is better.
Sensory.
Yeah.
What are the
Yeah. Okay. Yeah. It's going very easily through the skin. Yeah. Did you see that?
Yes.
Okay. And go again. In and till you see that. This is going to be very, very subtle, actually, kind of a pop. That's it. Okay. Did you see that one as well?
Yes, sir.
Okay. So that's the two pops. Always aspirate, and you can. Now, because this hasn't got any extension, I'll have to hold the needle, otherwise it moves. Okay. Can you see the coming back? Can you see that? Haithal?
Yes, sir, we can appreciate.
Yeah, you can appreciate. That means it is in the right plane. That's what we were saying yesterday. That if you're in the right plane, it will come out. But if you're in the muscle, then you won't see that. Can we add some more, please? 40 ml I'm going to give. Again, it's coming out easily.
Any distal pressure can help.
Sorry?
Any distal pressure will help.
Not necessary. Okay, another 10 ml.
Another in one block में
10 ml bucket.
distal pressure का.
Yeah. You can still see that it is actually come. हो गया?
Give me 10 ml local.
10 ml more.
He is preparing.
40 नहीं लिया था. ठीक है, कोई नहीं. It is demonstrated. It's fine. It's okay. Yeah, that's not a problem.
Are you giving any local anesthetic
This
with
is
facial attack?
Blood.
Yeah. Sorry?
Facial attack.
Hello.
Huh?
Sir, you any local anesthetic without facial attack or?
No, I will likely show this now because this patient had a surgery. So now we're going to do is the lateral cutaneous nerve block. Okay. So we given 30 ml for that. And that should go to the femoral and it should seep posteriorly as well, but to demonstrate your fascia
Lateral
or the lateral cutaneous nerve
nerve
block. So that is the anterocephalalic spine. Okay. On the inguinal ligament, you go 2 centimeters medially, 2 centimeters down. Okay. All you need is a. Okay. This is now nicely blunted now. Okay. Okay. So you go straight onto the fascia lata. Okay. And you actually feel a pop on the fascia lata. Okay. Very tough fascia. Bounce, 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 and pop. Okay. Did you see that?
Yes, sir.
Okay. Aspirate, and again, there isn't. Oh, sorry. There isn't any blood vessels, big blood vessels there, but you can actually have the superficial circumflex iliac artery, which is actually going from the femoral artery. That is just the lateral cutaneous. With your fascia iliaca, you have to still be careful. Your femoral gives out a circumflex, superficial circumflex iliac artery, which goes actually towards your point of injection. Okay. Yep. So that's all done. So we done the.
So for
fascia.
lateral cutaneous also 2 loss of resistance.
No, only single.
Only
We went through.
single.
Yeah. You have
I
to
can
go through.
remember the picture on our.
Yeah. So just the fascial lata, you pop the fascial lata, inject there, and it can actually come out and inject over the fascial lata as well to catch the cutaneous branches. But this will be fine.
Now how can it will when you are giving a fascia iliaca?
Yeah.
It is 2 layers deep. So
Yes,
how will
two.
it go to lateral cutaneous or at that level?
The lateral cutaneous actually the local anesthetic seeps along your psoas muscle
Proximally.
proximally,
Sort of.
and the lateral cutaneous is actually coming out almost halfway through that.
Acha.
So if
Before it
local
pierces
yeah,
the
yeah,
first layer.
yeah, absolutely. So it comes out
Yeah.
and then comes just under the fascial lata.
Okay.
So you can still get with fascial iliaca, you can get little cutaneous as well.
Oh.
That's why I'm saying you can actually use larger volume,
Yes.
40-50 mls for that, and you'll be fine.
You can use it for a skin grafting where only femoral
Yeah.
may not be sufficient and you
Yeah.
want the lateral cutaneous also to be blocked.
Yeah.
A fascia iliaca may work for that.
Yeah. So we could actually use that for taking graft from the other patient if you wanted to. We could have just done a little cutaneous block.
Yes.
But we would advise that you actually go under the fascial lata, come out and inject few mls because you get a cutaneous branches coming out through that as well.
Okay.
Okay. It also divides into multiple branches.
When we are injecting 40 ml, does it spread to obturator now or not?
I told you yesterday, it is never spreads to obturator.
It's a
you need to actually, you need to actually go higher up almost to the origin of the plexus.
3-in-1 block is a mix.
Yeah. Okay, so you will never get obturator now with fascia iliaca block or with 3-in-1 block. Yeah. You can actually give obturator nerve block as well. You can actually use nerve stimulator for
we can
obturator nerve.
demonstrate it also.
You need to just go your cubic tubercle. Okay.
2 centimeter.
Yeah,
below.
2 centimeter medially
I
and
mean
down, or
laterally.
you go below and down. Okay, and just going straight, and you will actually can get the obturator nerve.
If it is,
It is a deep one, so you need to at least use minimum of 5 centimeter needle.
It is amongst the adductor muscles.
Yeah,
It's in the way.
yeah. So you will actually see the adductor muscles getting stimulated. So for hip surgery, you can actually use obturator as well if you want. If you want to demonstrate and you got time, we can do that.
સર TURBT માં જર્ક આવે છે knee એના
Knee
માટે.
jerk, yeah, for that.
Spinal ભેગું
Yeah, okay, yeah.
obturator.
Yeah, you can, yeah. Do you want Hazel to demonstrate the obturator as well?
yes, sir.
Okay, let's do the obturator as well. There are 10 mls, just we need 10 mls, and I need the nerve stimulator.
Nerve stimulator. and
Yeah.
it will be-
And can we get a needle, please? I just need a 50 ml needle.
તકલીફ નથી ને કાંઈ?
Yeah, he won't feel anything. Yeah, he will be
Can you see,
pain.
sir?
Huh? Sorry.
See you, sir.
Yeah. I'm just getting a nerve stimulator needle.
Okay,
On
okay.
the same patient,
just
he is
open it.
demonstrating obturator block.
Yeah, can we have any electrode?
You have put an electrode? You have put an electrode?
તમને દુખાવા બધાય મટી જાય.
Sir, it does. The electrode is there. थोड़ा ऊपर ले लो.
Apply over here.
Have we cleaned the medial side?
No, I will clean it.
Can we clean
Sir, I'm applying the electrode.
Yeah, you
Okay?
can. Yeah, anywhere you can apply. You can apply on the other leg as well if you want. Forehead में भी लगा के दिखा सकते हैं. लगा दो forehead में. जय माता दी.
આ તો પિતાજી છે.
सर, आप माता दी क्यों बोलते हैं?
हमारे पिताजी को कौन याद करता है? सारी देवियों को पहले प्रणाम करना चाहिए, फिर उसके बाद पिताजी
પિતાજી તો
को.
ઓલા ભોયરામાં છૂટાઈ ગયા હોય છે ને.
He has not come from for workshop, but he is doing it very regularly and he is putting that blocks on our group to anesthetics also. So you can see all that blocks on that CD. They are very well demonstrated. You can see
Yeah.
it in your setup.
आप इधर आ जाओ. इधर आ जाओ.
Yes.
I don't know.